Welcome back to Oncology for the Inquisitive Mind. My name's Josh, that's Michael, and we're here to start the new part of our Back to the Basics series. We've spent 6 months on breast and genitourinary cancers because why not? But now we're going to be talking about lung cancer. But Michael had a heap of facts last time about things that happened in 1987. So I'm going to talk about at least one fact about Michael. Michael is a history buff and he loves dressing up as Indiana Jones. But
that was one time, Josh.
Still have the photo, Michael. Time. And I didn't even know you then. I have it on my phone. So, if you like and subscribe this episode, I will potentially, probably not, definitely not send you that picture of Michael when he was young, dressed up as Indiana Jones.
I don't know if that's a carrot or a stick, Josh. I think that you've actually driven subscribers away now.
Yeah, it's just a stick because they're like, what are we doing? This is not oncology. This is stickology.
Stickology, the study of sticks. So if you do like study of sticks, then you'd probably better go find another podcast. Ironically, if you like oncology at this point, you'd probably better find another podcast as well. Let's be honest.
No, but don't. Like, Michael, you've got the interesting stuff to talk about. So why don't we talk about early lung cancer, which is really what this topic is.
I think we should include an allegedly disclaimer because we go off topic so much. But
we might talk about oncology, but we might not. You can find out.
Yeah, who knows? That's the risk you take when you click on the link.
It's like beavers building a dam and you're down from that dam and then the dam breaks and then your house gets flooded. It's also got very high risk.
Yes, definitely something that happens outside of Looney Tunes, Josh. Anyway, lung cancer, specifically early lung cancer. Now, for us in Australia, this is a topic of great import because, Josh, it might be interesting at some point for us to do a specific episode looking at this. But we are having introduced a national screening program for lung cancer. Now, as anyone who's worked in this space will know, the diagnosis and long-term management rates of lung cancer up to this point have been pretty abysmal. Only 25% of those who have a diagnosis of lung cancer or newly diagnosed lung cancer have resectable disease. So 75%, it's already too late. It's metastatic, it's gone. But hopefully the lung cancer screening program will increase that number. The second problem is that almost half of patients who have curative surgery ultimately have recurrence. Even if you have a piddly little stage 1, you are still at a very high risk of recurrence. And most patients with lung cancer, early or advanced, ultimately die of their disease. So the attempt to fix this in the past has also been fairly miserable because the previous standard of care was adjuvant chemotherapy, either platinum plus pemetrexed or plus vinorelbine, depending on the subtype of non-small cell lung cancer. However, at best, this only improves things by about 5 to 6% in terms of overall survival. Complete pathological response is rare, obviously, because neoadjuvant chemotherapy has never really been a thing in the lung cancer space. Or should I say, until now, because the first study we're going to be talking about is, of course, Checkmate 816. I think we can call this a truly trailblazing study, Josh. So Checkmate 816 is a study of neoadjuvant chemotherapy and immunotherapy with nivolumab. The idea being that combining these two agents in the neoadjuvant setting provides an earlier opportunity to treat micrometastatic disease and enhance immune response. You want to enhance the immune response when the tumor bulk is still significant and the tumor antigens are still present. This has been scientifically, I guess, proved with the NADINA trial in melanoma space, and so similar theory in lung cancer. There is an earlier phase 2 study that confirmed neoadjuvant nivolumab alone or with chemotherapy had promising results regarding the complete pathological response rate, outcomes, and safety. So, in terms of the methodology for Checkmate 816, key eligibility criteria, patients had to have newly diagnosed resectable stage 1B to 3A non-small cell lung cancer, and that is something that we'll come back to per the AJCC 7th edition. ECOG performance status of 0 to 1, and they had to have no known sensitizing EGFR mutations or ALK alterations. And of course, Josh will come to at least one of those populations later in the episode.
Really? I thought I was doing testicular cancer, Michael.
Oh, Josh is just living in the past. Or that's where his head always is. Ultimately, that's not a question we want answered right now.
Wow.
The number I'm just pushing on under duress, I will have you know. The number of patients recruited to Checkmate 816, because that is actually what we're talking about, was 358, and they were randomized 1-to-1 to receive chemotherapy plus nivolumab or chemotherapy by itself. They had radiological restaging and surgery within 6 weeks of treatment, and both neoadjuvant cohorts had 3 cycles of neoadjuvant therapy. There was the option for adjuvant chemo and radiotherapy depending on the outcomes of surgery. The primary endpoints were the pathological complete response rate and event-free survival by blinded independent review. Secondary endpoints, major pathological response rate, overall survival, the time to death or distant metastases, and then exploratory endpoints, the overall response rate, and predictive biomarkers including PD-L1, TMB, tumor mutational burden, and ctDNA, circulating tumor DNA. So the results. Now, this is going to come in waves because I've got several updates here. Basically, in terms of the initial results, 83% of patients in the combination group and 75% in the chemo alone group underwent definitive surgery. 15 and 20% respectively did not make it to surgery, usually due to disease progression. And that is the fear with any neoadjuvant therapy, is that there are going to be a small number of patients that are inherently resistant to systemic therapy and you miss them. So they actually go from resectable to unresectable in the space of those 3 cycles. Aside from predictive biomarkers, there's not a whole lot we can do. That's, to put it slightly bluntly, probably could be a bit more sensitive, but that's the cost of doing business with this. And so selecting those patients that are going to advance and respond poorly to this therapy is an ongoing area of study. Very, very important. The initial results in terms of event-free survival was 31.6 months in the combination arm and 20 months in the chemotherapy alone group, with a hazard ratio of 0.63, and this was statistically significant. Survival without disease progression at 2 years was 63.8 compared to 45.3%. And if you adjusted for the presence or absence of adjuvant therapy, because remember that was optional, the hazard ratio was still 0.65, again hinting at the fact that adjuvant therapy doesn't really do much in this space. The magnitude of benefit was better in stage 3A than stage 1B or stage 2, but there was a smaller proportion of events that had been recorded in the latter group. The benefit was present, I guess, across most subgroups. The major pathological response was higher with nivolumab plus chemotherapy than chemotherapy alone. You might be sensing a theme here, both in the primary analysis group and across key subgroups. The odds ratio, incidentally, of having a major pathological response was 5.7. So with the addition of immunotherapy, theoretically, you have almost a 6-fold improvement in your likelihood of having a major pathological response. Unsurprisingly, a lot more people in the Nivo plus chemo arm had a complete pathological response as well. I might just skip ahead in the interest of time, Josh, in terms of the most recent update, because we have 5-year data with a median of 68 months of follow-up. The overall survival in the chemo IO arm, Josh, for a lung cancer study, this is brilliant. Still not reached, which is fantastic.
Unknown, right?
Unknown, yeah, unprecedented. Compared to 73.7 months in the chemotherapy alone arm, hazard ratio of 0.72, and by the thinnest of whiskers, this is statistically significant with a p-value of 0.0479. The 5-year overall survival rate was 65 compared to 55%. 5-year overall survival amongst patients who achieved a PCR, 95% in the chemo IO arm compared to 56% in the chemo alone arm. Now, I talked about biomarkers before. Positive markers of a greater magnitude of benefit. I mentioned stage 3A disease, but also a PD-L1 expression of greater than or equal to 1% was associated with better outcomes with a hazard ratio of 0.51. And there's been long-term follow-up with ctDNA, as mentioned before. So patients with pre-surgical ctDNA clearance were established to have better outcomes, and ongoing follow-up has confirmed that. They have continued overall survival improvement in both arms for those who cleared their ctDNA before surgery compared to those who did not. So, brilliant study, fantastic, game-changing. This is now the standard of care, and I'm pretty sure it's actually been approved by the PBS because I have seen it used in Australia, so that's fantastic. It should now be considered standard of care. A couple of questions though, and I'm sure these will be teased out. Who needs chemotherapy? How much is the chemotherapy, quote unquote, backbone actually contributing, given that we know that chemo by itself is not very effective. Do the patients with earlier stage, so stage 1B disease, actually need the chemotherapy? Or can they just get neoadjuvant immunotherapy? Or can they just have surgery by itself? Probably not, but how can we actually reduce the intensity of treatment? Because I'm sure there are patients in this cohort that we are overtreating. Going to the other end of the spectrum, what about patients with disease that is more advanced than stage 3A? The patients that in classical times, pre-neoadjuvant therapy times, would be considered completely unresectable. Locally advanced unresectable, you treat them basically as metastatic or try and get them definitive chemo, rads, and durva. So with this regimen, for these patients who were excluded from this study, can we get these operable? Can we convert them from an inoperable cancer to an operable cancer, or are we going to lose more to distant metastatic disease? And finally, Josh, and I've been saving this one for last because it segues very nicely, if I may say so myself, into your study. What about patients with targetable mutations?
It's a great segue, Michael, but I think a couple of things I'd like to little pointers. You're right, it's a great study. It's really great. There's some issues as well about the use of some neoadjuvant chemotherapy. As you said, not really validated. It's not really the standard of care. It's poor outcome. So my question in that, why didn't they use adjuvant chemotherapy in that context, right? Because you did sort of mention it, but it's something it's important to note. There's all this information and sort of questions about using ctDNA to try and validate who to give therapy and then who do you give adjuvant therapy to. So that's really unknown and interesting question. The surgical operations and who defines what's operable. There's a table out there, and I don't have it here, but it's like these are all operable. These are not operable. There's no defined consensus on technically operable disease.
Yeah. And it depends on the person. Like, I'm sure there will be surgeons who will say, yeah, I'll have a crack at that. And there will surgeons say, I'm not going to touch it.
And then the real world data, how people are like, this is operable, but it'd be great to give it to downstage, but technically it's not approved. Anyway, that's a small list because I went to a couple of talks about this. You see, I do like lung cancer. It's a breath of fresh air.
Because it's in the lungs, I get it. But very good questions. The neoadjuvant chemo question is a good one, but I guess the alternative would be comparing it to nothing, because there is the option for adjuvant in both arms, depending on preference. But yes, chemo neoadjuvantly by itself, not really a standard of care.
Yeah, but moving on, because we were trying to keep these episodes, I say on track, Michael. It just is not a thing.
Yeah, despite abundant evidence to the contrary.
It's like when I try and play any computer game, I'm never on track because I'm terrible at technology. But
yes,
neoADAURA, as expected, it is the use of osimertinib before surgery in the EGFR mutated population, which hasn't been done. It's been definitely proven in the adjuvant setting. It's been proven beyond doubt in the metastatic setting. It has blown past gefitinib, all the other nibs that came up, like 3 or 4.
erlotinib. That's probably the one you're grasping for.
Yeah, I grasp at a lot of things, Michael.
Crizotinib is there, but that's more Alkan ROS1. But it's also a nib.
The nibbles. It's nibbles. I love a good nib. Anyway, so look, it was, what is osimertinib? It's an irreversible oral epidermal growth factor receptor tyrosine kinase inhibitor, which potently and selectively inhibits both EGFR TKI sensitizing and EGFR T790 resistant mutations. No longer do we have to do the T790M testing, Michael. I've already mentioned where it's great, the ADAURA trial, other trials. The background in which Michael covered is that, what do we do with the chemotherapy, the non-small cell lung cancer cohort? There's not a lot of data with immunotherapy in this cohort of patients. We know, we don't know, but now we know, because I'm about to say it, that PCR post neoadjuvant chemo is 0 to 4%. It is shocking. There's been heaps of great trials, though. Michael's one, check that out at the start of this episode if you haven't listened to it. Checkmate 816.
If you just scroll through until I stopped talking and then went straight to Josh.
And there's the Niagara trial, which we'll talk about, I'm sure, in a later episode. But this trial was resectable. So stage 2, 3A, and 3B, EGFR exon 19 or 21 mutation, surgically resectable, good performance status, 3 arms, OSI alone, OSI plus chemotherapy, or chemotherapy alone, followed by surgery, with a major endpoint being major pathological response, not pathological complete response, because that's one of the issues. Secondary endpoints being event-free survival, pathological complete response, and overall survival. Patients were given 9 weeks of TKI, and then they were operated on within 12 weeks. So pretty short turnaround time post chemo, but it's also important. The big thing with all these trials, Michael, yours, mine, is that especially people in regional settings, when it takes so long to define what's resectable, this stuff is really hard. And I think that's something to actually acknowledge. Aside is that it's hard to get people from A to Z or Z because we're, a British colony still.
Because we're not American.
We're not American. We're a British colony. I like my tea. Thank you. I was just lost it. My wife says I can't do accents to save my life.
I've just facepalmed the microphone, Josh. Well done. Congratulations.
So the definition of major pathological response is less than 10% residual viable tumor. Patients were in their 60s. About a third of patients were smokers or previous smokers, which I thought was interesting. At least a quarter were Chinese, 50% non-Asians, young female Asian. That's the predominant cohort here, but not just those. There are other people as well. And about half was stage 2, stage 3. Lymph nodes about N2 were about 40% or 30 to 40%, and N1 was sort of 35 to 38. When you look at the major pathological response, there wasn't much between arm A and arm B, being Aussie plus chemo versus Aussie alone. It was about 26 versus 25%. They didn't do a statistical comparison of these. That's just a numerical listing versus 2%. So evidently, we're seeing something happen here, and that's that osimertinib works okay. In this sub-analysis, we see everything benefits as osimertinib. And in the subgroup for Aussie mono versus placebo plus chemotherapy, again, everything favors osimertinib with smoking, race, sex, patients, etc., etc. The waterfall plot looking at regression of the tumor was relatively good. You can sort of see while a number of people had 100%, if you look at sort of 50% or plus, it's over 50 or 60% of patients in that group of patients. And you look at chemotherapy, wasn't a lot. In the N2 disease cohort, just important points, downstaging in 53%, which is great. And they're the really high risk guys, aren't they? Versus 21% in chemo. This is an interim analysis. So first of all, it's really early data, 15% data maturity, and the median duration of event-free survival was 14 months. So not a lot of time to really give huge outcomes with that. So the hazard ratio was 0.5, not there yet. That was the Aussie plus chemo versus chemo. And the osimertinib, I shouldn't abbreviate, monotherapy versus chemotherapy was 0.73, but there wasn't a statistical comparison. But you don't need to have it for this. But they should have had a statistical comparison in this trial. I feel that would have been really important, especially considering they know it was going to be a great drug. So that's all the really interesting thing, isn't it? The number of patients who had not experienced event-free survival events in the 3 arms was 93 versus 95 versus 83%, with the latest number there being that chemotherapy. And you can sort of see the Kaplan-Meier curve slowly decline in that cohort of patients, but not reached in really any arm. There are a lot of notes about this trial, Michael, because you're like, where's all my answers? Well, we don't have a lot of answers. The first question is major pathological response, a surrogate for PCR. We don't know. Major pathological response is better than no major pathological response. The results of improved overall survival is just not known. So 90% of patients who underwent neoADAURA underwent adjuvant osimertinib in all 3 groups as per standard of care. How do we then break that down? But look, really interesting and unknown outcomes, right? Because adjuvant, we already know that's established. So are we actually improving? So unless you have neoadjuvant plus adjuvant versus adjuvant in this trial, which would actually be really good. But as a drug company, I wouldn't want to do that because I then give 9 extra weeks of treatment. And if someone lives long, actually, it'd be a great trial. If someone lives longer with neoadjuvant, then you can stay on osimertinib for the rest of your life. Hunky-dory, very happy. Other unknowns is relapse patterns, mechanisms of resistance, overall survival, and are there a subset of patients where it would actually be preferable just to give neoadjuvant? We don't know. And also, like you said with your trial, borderline resectable patients, if we downstage, do they get the same outcomes as those that are resectable? And that's just me doing some little bit of literature reading around this topic about some of the issues with it. So it's not that it's a bad trial. It's just that I need more. it's not that it's bad, but I wouldn't approve this on the PBS if I was the person looking at it. I mean, maybe it is approved. I don't think it is. They're my very basic questions.
No, they're very good questions, Josh. And I think we've talked about this when it first came out. The biggest question with this study is exactly as you said, neoadjuvant versus adjuvant. ADAURA is brilliant. neoADAURA also great. There's some questions as well. I don't know if you remember about how long adjuvant osimertinib needs to keep going for, because there was a drop-off, I think, after 2 years for those who stopped osimertinib. Their recurrence rates went up compared to those who continued on it. Can we sandwich it? Can we do like what they did with pembrolizumab and melanoma, where you do 3 cycles before, 3 cycles after? Can we do that? This is your favorite topic, time toxicity and financial toxicity related to this. I mean, as you say, if we're adding neoadjuvant osimertinib to adjuvant, that's probably not going to get much better than adjuvant, I would imagine. If you're doing neoadjuvant, you'd want to have some corresponding decrease in the amount of adjuvant therapy. But these are all questions that we don't know. And as you said, I think to summarize this, because we're over time, that we do need a neoadjuvant only plus, or neoadjuvant and adjuvant plus adjuvant versus adjuvant only study. That's really the only way we could tease this out.
Yeah, I think that's it. And I think, look, it was a great idea. And what I'd actually like to see is neoadjuvant versus no adjuvant. That would be really, really, really phenomenal.
It will be very interesting. Will it happen though? Who knows?
Maybe not. But also the question is, if you do that, do they get 5 years and then you then give them again osimertinib? Lots of unanswered questions. I'll leave the smart people to think about that.
That's a very good question is, at what point, for those people who do recur, at what point do we say they're resistant to osimertinib versus they've just sort of lapsed? All questions that need to be answered by smarter people than us.
Yeah, that's it. But we like to talk about it like we are smart. So Michael, can I talk about what we're doing next week?
Please do, Josh. Take us out.
We're in the land of lung. I feel you should have added in a couple of extra episodes. This is not doing us justification.
We can ride by the seat of our pants here, Josh.
Yeah, I feel you need to do some elk stuff as well. Oh, Crown's there. Okay, cool. I'm like, Michael, there's other things.
Glaring empty space for ALK. No, don't worry.
And mesothelioma? Like, is there any mesothelioma here?
That's a good thing. We should do that.
Oh, Michael. No, I'm kidding. So next week, we are talking about non-mutations, advanced non-small cell lung cancer. Stay tuned, where Mike will give you some insights, and I'll probably just throw a couple of lame dad jokes in. But looking forward to seeing you then.
Look forward to seeing you then, Josh. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.